Hello. So the title of my presentation today is Overcoming Challenges in Epidemic Prediction. And I will focus on some of the work that we have been conducting over the last few years in this direction, in developing methods and models that can help us improve our ability to predict epidemics and pandemics. So I will start by presenting the famous SIR model that many of you know. Just to point out that this is the framework, the building block of mathematical epidemiology. The main assumption here is that the population is well mixed, and the probability that an infected individual interacts with any other susceptible individual in that spatial unit in that population is the same across all of the contacts. As a result of this assumption, the epidemic grows exponentially fast whenever R0, the basic reproduction number, is greater than 1. This building block is employed across many different infectious diseases, whether that's Ebola or SARS or SARS-CoV-2. And so I would argue that there is a need to refine these models while keeping the complexity level limited in order to improve our ability to forecast different types of infectious diseases. Indeed, when the model is for the SIR model, if we are attempting to predict the early course of the epidemic, the trajectory will follow an exponential growth trend. And this is true for all of the SIR models in the absence of any type of intervention. However, some infectious diseases display variable epidemic growth patterns, and in particular sub-exponential, slower than exponential patterns that may be related to the type of contact that drives the transmission dynamics. And so that's something I will be arguing for in the next few slides. Indeed, real epidemics exhibit variable epidemic growth scaling, in that epidemic growth scaling is related to the mode of transmission, behavior changes, spatial effects related to the type of disease, the epidemiology of the disease, and other heterogeneities at the individual level that we may or may not be aware of. The initial phase of the HIV epidemic in the United States during the first few years was characterized by sub-exponential growth. Indeed, in this paper by Colgate et al., the early dynamics of the HIV epidemic was characterized by a cubic polynomial, as you can see in this picture, most likely related to the fact that HIV/AIDS is transmitted by an intimate contact, direct contact, or through intravenous drug use. This is also the case for the Ebola epidemics. This figure shows the subnational level epidemic curves of the 2014 Ebola epidemic in Guinea, where we can see that at that refined spatial scale, the epidemics are characterized by early sub-exponential growth. In this graph, you can see the y-axis is in log scale. So the epidemics grow quickly, but they saturate quickly also. This is probably related to the fact that Ebola is not transmitted through the air, like COVID-19, but it's transmitted through a close contact, an intimate contact, and most of the infections occur between an infectious individual and a caretaker. This is a characterization of the early spread of the Ebola epidemic in West Africa, where we can see that most of the early infections occurred among relatives, caretakers, including healthcare workers and nurses, suggesting a particular type of spatial transmission pattern that needs to be taken into account in the models of Ebola transmission. So if we want to incorporate spatial structure in the models, perhaps the simplest way is to define two levels of mixing. household level mixing and community level mixing. In this particular model that was devised in 2014 by Maria Kiskowski at University of South Alabama, we can see that households belongs to communities. So individuals mix at the household level, but the individuals also mix at the community level, and the communities are overlapping, okay? So we need two parameters, the size of the households and the size of the communities in terms of the number of households per community. In this graph, you can see an example of the type of spreading wave that we can obtain with that type of spatial model. It's like a wave of transmission that goes through the population and saturates across the population. And in particular, the early dynamics are characterized by sub-exponential growth, as we can see in this slide. And that means that the reproduction number, even at the onset, starts to decline rapidly as a result of the sub-exponential growth dynamic. The solid line here corresponds to the corresponding exponential growth dynamic, which is not happening. And C, the parameter C, corresponds to the household, to the community size in terms of the number of houses per community. So we can see that as we increase the community size, we can also expect to observe a little faster growth. But even with communities of 65 households, the growth dynamic is still sub-exponential. Now we can go beyond the earlier growth dynamics that are important to predict the course of epidemics and talk about the fact that epidemics are composed by different sub-epidemics, a number of sub-epidemics, what we call sub-epidemics or sub-outbreaks. These sub-epidemics are the result of different mechanisms. For instance, we can be thinking about transmission in particular risk groups such as MSM transmission that later spills over into the general population, into the heterosexual population, or transmission dynamics that are occurring in different spatial units within the same population. So for instance, we can see that the early outbreaks occur among people that travel abroad and bring the pathogen to their communities, and later on spreads to the general population. So this is exactly what we are seeing for the COVID-19 pandemic, that the epidemic curve is the aggregation of multiple sub-epidemics that in some instances can be characterized. And if we can do that, we can improve our ability to forecast epidemics, the pandemics at different spatial scales. So here you see the current epidemic curve for at the national level of the COVID-19 pandemic in the United States, where we can see that the pathogen arrived, it hasn't left, and we can look at this epidemic curve at the national level as the aggregation of multiple sub-epidemics. And each sub-epidemic is the result of particular mechanisms, transmission dynamics occurring within high-risk groups such as long-term nursing homes, healthcare settings, households, or in particular age groups during the summer that later spread the virus to other populations, and so forth. So the challenge here would be to find a way to characterize these sub-epidemics, the underlying dynamics, in order to improve our ability to forecast, at least in the short term, the pandemic. In this direction, in 2019, we put forward a framework to forecast epidemics based on the underlying principle that epidemic curves are the composition of multiple sub-epidemics. You can see on the left the concept that we could have different transmission trees that we hardly observe And those transmission trees can give rise to a very similar epidemic curve, right? So in other words, when we have the epidemic curve, our ability to go back and disentangle the transmission tree is very difficult in the absence of detailed contact tracing data. But perhaps some information could be helpful to disentangle subepidemics. And in fact, on the right panel, you can see a SARS outbreak in 2003 that involved healthcare settings in Singapore, right? And the corresponding epidemic curve in the bottom, where we can see that the first peak, the first subepidemic affected a particular healthcare setting the most. And then after that, there was a second surge that affected other healthcare settings. And so this is just to illustrate how some information about where the virus is spreading could help us characterize different modes of transmission, different peaks. And by doing that, we can improve our ability to predict. So the building block is a phenomenological model at this moment, is what we call the generalized logistic growth model that incorporates three parameters: the growth rate, the scaling of growth parameter, or the acceleration of growth parameter P. The parameter K is the size of the epidemic. And so if we are able to disintegrate the epidemic curves in terms of this building block with mathematical and statistical frameworks, we can attempt to improve our ability to predict, and that's what I will be doing in the next few slides. So this is the mathematical expression, the mathematical equations for this model, where you can see that the index I corresponds to subepidemic I. So each subepidemic is one equation, generalized growth equation, and then subsequent subepidemics have the same growth rate and scaling of growth parameter, but the size of the subepidemic could be changing over time, perhaps could be declining as a result of interventions, or could be increasing as a result of relaxation of public health measures. And importantly, these subepidemics are not synchronous, but they are inherently asynchronous. So they are being triggered at later consecutive times. As you can see here, the parameter C2 sub THR corresponds to the threshold, the community number of cases that the current subepidemic needs to reach before the next subepidemic is triggered. Okay. And so this is the definition of this framework. This is an example where the red curves correspond to one subepidemic and the multiple curves correspond to uncertainty that we will discuss more. And the blue curves correspond to the second subepidemic. And you can see here the third subepidemic is starting to take off. So if we assume that the later subepidemics start to decline as a result of interventions or behavior changes, we can characterize those sizes with this equation, where parameter Q denotes, represents, or captures the impact, the intensity of those interventions or behavior changes that mitigate transmission. And it is nice that we are able to write a closed form equation for the final size of the overall wave of the overall wave of the epidemic or pandemic. So regardless of whether we have 2 or 3 or 100 subepidemics, we can readily compute the size of these subepidemics. Here, these panels illustrate different qualitative behaviors of the subepidemic modeling framework, from endemic states that result from the aggregation of subepidemics of the same size and equally spaced that are strongly overlapping with each other, to subepidemics that decline over time, that give rise to an epidemic wave with a slowly declining tail, two subepidemics that give rise to epidemic curves with oscillations, sustained oscillations, or damped oscillations if the subepidemics are declining over time. So how do we connect this model with the data? In order to do that, we need a statistical estimation framework. We use parametric bootstrapping. That means that we feed the model to the data, and then we generate additional data based on that best fit to the data in order to generate confidence intervals and prediction intervals. In this framework, we have 5 parameters: the threshold CTHR, at which the next subepidemic takes off; R, the growth rate; P, the scaling of growth parameter; Q, the intensity of interventions or behavior changes; and K is the size of the subepidemic. There are different performance metrics that can be employed. Here are some of the most commonly used. One of the challenges is to define common metrics so that different modeling teams employ consistent metrics across studies that would facilitate a comparison of models' performance. Here's an example of fitting the subepidemic wave model to the 2003 SARS outbreak in Singapore, where we can see that the model is able to characterize the 2 peaks and infers 2 subepidemics, which is nice. The parameters are well identified from the data. The residuals are well behaved overall. Here's an example of using the subepidemic modeling framework to forecast the epidemic in the United States, where we can see that the subepidemic modeling framework does a good job at short-term forecasting once the epidemic curve starts to reach a saturation point. Before that, we see that the framework underpredicts, which is expected because it doesn't have more information about where the epidemic is going. But once we have more data about where the saturation is happening, how it is happening, we can improve our ability to forecast. And so you can see here, for instance, how the model, the framework, predicts several subepidemics, right? And by doing that, we are able to predict the pattern in the next 20 to 30 days. Here's a comparison of the performance of the subepidemic modeling framework with a model with a single epidemic curve like the Richards model, where we can see that there is a substantial improvement across different performance metrics. Here's another example using data from Spain, which is interesting to see how the modeling framework captures these subepidemics. 2 subepidemics. The vertical line separates the calibration from the forecasting periods. And we can see that the modeling framework predicts the 3rd subepidemic in green that actually took place, as you can see in this slide. The resurgence is happening there. And this is the fit of the model to the entire data of the first wave in Spain, where we can see that indeed the model predicts at least 3 subepidemics. The parameters are well identified from the data. We have been using the modeling framework to forecast the pandemic in the United States at the national level, at the state level as well. And we have been publishing the national level forecasts over the last few months or consistently. Where you can see that the model is doing a reasonable job, pretty good job at forecasting. One of the challenges with forecasting the pandemic at the national level is the substantial variability in the case counts. There's so much noise that we need to understand in order to improve our ability to forecast even better. But as you can see here, this is the forecast for October 26th. The model is able to capture the patterns, in this case, from September, early September, all the way to October 26th. by allowing the model to infer sub-epidemics. Here's one more. This is the November 9th forecast. And over time, we have been doing some improvements, better capturing that over dispersion, modeling the noise has led to improvements in our forecasting performance. And importantly, this is one of the few efforts that are documenting not only the forecasting performance, but also how well the model have been calibrated with the data, with the historical data. And as you can see, the model is explaining well the historical pattern, the most recent historical pattern, and that gives support for the forecast. Here's one more. This is November 17th. This is one of the most recent ones. This is January 21st, where we started to capture here the declining phase, the most recent declining phase that we have been seeing, and it has been consistent. And we have been capturing that pretty well. You can see here. This is one of the most recent ones. So overall, we have learned that by disintegrating the epidemic curve in systematic ways can lead us to improvements in epidemic forecasting. But at the same time, there are challenges in handling noisy data that result from variability in testing rates over time that need to be, that calls for further improvements. And we are also incorporating spatial features with the goal of improving epidemic forecasts. So if some areas in the United States are seeing different growth dynamics, if we're able to understand or model the heterogeneity separately, we can improve further the forecasts. Another front we have been exploring is methods to ensemble multiple models. So the idea with ensemble modeling, very briefly, is that if you have multiple models that you are using to predict the course of an epidemic, perhaps by integrating their ability to forecast into a single model can lead you to significant improvements in forecasting. And recently, we have been working with Dr. Ruyan Luo on this front. Dr. Ruyan Luo, who is a colleague at the Department of Population Health Sciences at Georgia State University. We have been exploring different ways of combining these models into the ensemble. And specifically, we have been using two different types of ensembles. The first ensemble in the top panel indicates that we basically take the average of the models, weighted average, based on their ability to, based on their forecasting performance, the individual forecasting performance of the models. In the second way of ensembling models, we randomly choose different models for each time point with a probability that corresponds to the weight that captures how well the model is explaining the data. So instead of taking averages, we are randomly choosing different models at different time points. And with the models that are doing better, getting selected more frequently. And what we are seeing is that this second ensemble is actually improving, provides an improvement in the ensemble that is consistent across different types of data sets, infectious disease outbreaks from Ebola, Zika, and COVID-19, and outcompetes the first ensemble modeling as well as the individual models. Here's an example with the epidemic curve for COVID-19 in Anhui, China, where we can see that ensemble 2 tends to get better coverage of the data, for instance, that you can see here by eye inspection. Here are the performance metrics where we can see that the ensemble 2 gets better, improved coverage, and lower MIS, which is a mean interval score. Lower MIS indicates improved performance. Here's another example with similar results. And the paper is actually published recently in the BMC research methodology. Beyond phenomenological empirical patterns and modeling frameworks, it's also important to predict what are the optimal ways of allocating resources to mitigate the impact of pandemics. And this is work with colleagues at UC Davis. We have been using optimal control frameworks and mathematical modeling to predict where the limited number of vaccine doses need to be allocated. We have been using deterministic models, H-structure models, but importantly, we have added the essential workers structure into the model. There are a few models out there that have accounted for H-structure, but the essential work component has not been studied. And this is one of the novelties in this work, as well as the fact that we're actually looking for the optimal strategies. And the optimal solutions will depend on whether we want to minimize the number of infections, the number of deaths, or the number of life lost. And it is really a dynamic approach because the allocation of vaccines can be changing over time, depending on the amount of vaccines, depending on the epidemiological situation, depending on the efficacy of the vaccine, et cetera, et cetera. Here's a quick view of the model. As I said, it's an H-structure model with age groups as well as essential work groups, a younger essential worker and older essential worker group. Here is a simulation of the model with the base scenario, where you can see how on this base scenario, compares with different allocations of the vaccines, depending on the objective, whether we want to minimize deaths or infections of years of life lost. There is a panel that illustrates how different strategies work. And overall, what we are seeing is that indeed it is important to allocate vaccines among the older population, but in some scenarios, particularly if the vaccines are being rolled out relatively quickly, you can actually improve your outcomes by prioritizing vaccines among older essential workers as well, in particular. Okay. So that's one of the main results that we have. And the fact that we have explored substantial sensitivity analysis and we have tried to convey the messages on the optimal strategies depending on the sensitivity and uncertainty of the parameters. Finally, acknowledgements to my collaborators and my graduate students, Kimberly and Rusa, who graduated last summer and now joined Dr. Nina Pfefferman at University of Tennessee. And Amna Tariq, who is my PhD student, second year PhD student, who has been working also very hard on the pandemic. And Jiseo Lee, who's an NMPH graduate student that also graduated and went back to South Korea to do work in public health, and many collaborators. Hopefully I didn't miss anyone relevant to this presentation. Probably I missed someone that have contributed in one way or the other in this work. So thank you very much.